Hi, I'm Doug Pleskow. I'm a professor of medicine at Harvard Medical School, and I work at Beth Israel Deaconess Medical Center, where I am the Associate Chief of Gastroenterology. My topic today is Barrett's esophagus, whom and how to treat. These are my disclosures. Let's start with the definition of Barrett's. This is a very important discussion that we need to make because of the key findings on Barrett's esophagus. There are two parts of this description. One is that Barrett's esophagus is the condition in which an abnormal columnar epithelium replaces the stratified squamous epithelium that normally lines the distal esophagus. It's a consequence of chronic GERD and predisposes towards the development of adenocarcinoma of the esophagus. But this diagnosis of Barrett's depends on both the endoscopic as well as the histologic evidence of metaplasia. Endoscopically, there has to be columnar epithelium within the tubular part of the esophagus. And histologically, even more importantly, the epithelium must be metaplastic, as defined by the presence of goblet cells. These two factors are what makes the diagnosis of Barrett's esophagus. Now, what are our risk factors for Barrett's? They include chronic gastroesophageal reflux. It is much more prevalent in the Caucasians, much more so than in Asians and African Americans. In fact, it's 10 times more likely. It increases with advancing age, so those over age 50 are at higher risk. It's much more common in males and females, and is certainly related to central obesity. Patients who have a BMI greater than 30 are at higher risk. Patients with a family history of either esophageal cancer or Barrett's esophagus are at higher risk. Tobacco abuse is a risk factor, but interestingly, alcohol intake is not a risk factor for Barrett's esophagus, although it is a factor for squamous cancer. The pathophysiology of Barrett's esophagus includes the genesis of proximal migration of stem cells from the gastrocardia up into the tubular esophagus. Expansion of these nests of residual embryonic type cells are located at the GE junction. There may also be a unique population of transitional basal cells located at the squamocolumnar junction as well. The last hypothesis is there may be circulating stem cells from the bone marrow that get transported through the blood to the damaged esophagus, and then these differentiate into columnar cells. It's not really clear at this point which of any of these hypotheses are the true pathogenesis of Barrett's metaplasia. The risk of cancer progression for Barrett's with patients with non-dysplastic Barrett's is fairly low. It's about 0.2 to 0.5% per year. However, when we get to low-grade dysplasia, the annual risk of progression to cancer is approximately 0.7% per year. With the progression to high-grade dysplasia, neoplastic risk increases to 7%. We also know that 50% of the patients who are diagnosed with esophageal adenocarcinoma don't have known Barrett's esophagus. And this is probably due to just lack of screening of patients who are at risk. And we'll talk about that in a little bit. In addition, the majority of patients who are diagnosed with Barrett's esophagus will die from other causes than esophageal cancer. So this is what happens endoscopically as well as pathologically. Squamous mucosa is exposed to injury from acid and bile reflux as well as nitrous oxide. This leads to chronic inflammation. And with the addition of genetic changes, including factors of gender, race, and other factors, possibly COX-2 inhibitors, Barrett's esophagus develops. Over time, the accumulation of genetic changes leads to the genesis of low-grade dysplasia, then high-grade dysplasia, and then eventually invasive adenocarcinoma. The mechanisms of malignant transformation include several different factors, including alterations in tumor suppressor genes p53 and p16. And these tumor suppressor genes are now being measured more frequently by our pathologists to indicate the risk of Barrett's esophagus as well as progression to cancer. Cyclin D proto-oncogene and aneuploid or tetraploid populations found on flow cytometry are also found in 90% of adenocarcinomas. When these changes accumulate, a clone of malignant cells emerges that has the ability to invade adjacent tissues and to proliferate into unnatural locations. I think we're all familiar with this, and that there is a change in esophageal adenocarcinoma incidence. It parallels obesity in our populations. The higher the rate of obesity, the higher the rate of esophageal adenocarcinoma. And it increases with age. In 2021, there were approximately 20,000 cases of adenocarcinoma of the esophagus. And at the same time, there were about 16,000 deaths due to esophageal adenocarcinoma. It's therefore known that this is quite a significant problem. Screening and surveillance with endoscopy allows for the detection of cancer in an early stage, but earlier detection with surveillance will probably lead to favorable patient outcomes with improved survival. Currently, multiple endoscopic techniques are available to treat dysplastic Barrett's and early adenocarcinoma, and we'll get to that shortly. But we have multiple guidelines for screening, and I'm going to highlight the American College of Gastroenterology guidelines over on our farther right. We do have AGA guidelines, British Society, ASGE, and the ESG guidelines as well. But I think the most important one is the ACG guidelines from most recently that was published in 2022. The guidelines include chronic gastroesophageal reflux with greater than 3 risk factors. So we want to include those male patients, those that are greater than 50 years, certainly concentrate on Caucasian men, those with central obesity, a history of smoking, and those with a first-degree relative of Barrett's esophagus and adenocarcinoma. Considerations for screening, however, is quite enormous. Many patients with Barrett's esophagus are asymptomatic, about 6 to 25% in the literature. Less than 10% of those with adenocarcinoma have a prior diagnosis of Barrett's esophagus. So we don't seem to be screening those patients that are high risk. Our current tools for screening and surveillance include the endoscopic routes, including upper endoscopy, using chromoendoscopy, magnification, virtual chromoendoscopy, and the recent addition of Watts, TissueCypher, PCLE, and spectroscopy. The latter are more often seen in specialized centers. There are newer non-endoscopic tools, which I'll discuss briefly, and the rationale for this. And these are recently included in the ACG guidelines as well. And those include Cytosponge, EsoGuard, and ESO. These are the tools that are available. Cytosponge, you can see here, is a sponge on the end of a tethered capsule. EsoGuard is a balloon that is on the end of a tethered device as well. And then EsoCap, again, which is similar to the other two. The Cytosponge is tethered to a string. This is encapsulated in a gelatin, which eventually dissolves when swallowed after factors, including TRFL3, which is a cellular marker that highlights the early goblet cells. There are multiple studies by Rebecca Fitzgerald's group out of England demonstrating the effectiveness. The most recent study is the BEST-3 study, which they evaluated 13,000 patients, and they had a 10 times greater rate of detection of Barrett's versus usual care, which included just potential for endoscopy and surveillance. In a more recent study in 2024 by 125 patients were evaluated, 81 with Barrett's and 44 with control. The sensitivity was very good at 88%, with specificity as well at 84%. EsoCheck and EsoGuard was born at the Case Western University out of Amitabh Chak's lab. This tool is tethered to a silicon catheter. It's an encapsulated balloon, and then that balloon is inflated with air and then withdrawn. This balloon measures DNA, a methylated vimentin, and cyclin A1A. In a recent study published in 2024 in the Red Journal, 360 patients were enrolled with 243 evaluable patients. When they look at the VIM, sensitivity was very high of 86 with sensitivity of 78%. When they measured CNA1, it was 92% and 73%. When these two were combined, the sensitivity and specificity were also very good at 85%. So a very valuable tool, and this is now commercially available as well. The next tool is another sponge on the string device. It's tethered. It's a 25 millimeter balloon that measures methylated DNA biomarkers. It measures VAV guanine nucleotide exchange factor 3 and zinc finger protein 682. A recent pilot trial on 41 patients also showed that this was successfully swallowed, and there was 100% sensitivity and specificity for diagnosing Barrett's esophagus. Our guidelines for surveillance are pretty clear. The length of the Barrett's is a predictor for progression to high-grade dysplasia and esophageal adenocarcinoma. Current guidelines suggest surveillance endoscopy every 3 to 5 years based on the low risk of progression. European guidelines are a little bit different and suggesting endoscopy every 3 to 5 years based upon the length of Barrett's esophagus, with greater than 3 centimeters every 3 years and less than 3 centimeters every 5 years. But we do have problems with our current strategy. Our dysplasia is fairly patchy and only biopsies a fraction of our Barrett's epithelium. It's time-consuming and expensive. Dysplasia in early adenocarcinoma can't be distinguished sometimes endoscopically from non-dysplastic Barrett's. There's a variability of techniques, and many endoscopists actually don't follow current surveillance protocols. This was a study which demonstrated that there is really poor compliance to biopsy protocols. This is from the GI Quick data. There were 2,245 surveillance cases. Adherence rate to Seattle protocol was about half. And the odds ratio for adherence for 3 to 5 centimeters was better than those for 6 to 8 centimeters and much poorer for those greater than 9 centimeters. Worsening compliance is noted with increased length of Barrett's esophagus on another study from the Netherlands, which showed Seattle protocol biopsies were taken in 0 to 5 centimeters at 79% of the time, 5 to 10 centimeters, 50% of the time, and those that are greater than 10 centimeters, only 30% of the time. Barrett's esophagus in 2024. Our current endoscopes are really very good, and we have high definition in virtual chromoendoscopy, which are the standard of care and should be used on everybody. In the future, however, we're going to get 4K HD TV and 3D endoscopy as tools that we can use. Currently, however, the weakest link is us. It's the endoscopist. Jacques Bergman, a Barrett's esophagologist in the Netherlands at the University of Amsterdam, says you don't detect what you see, you detect what you recognize. I think a lot of us are not really expert at understanding what we're looking at to try and identify what Barrett's are. There's some really good sites that help you become a better endoscopist, and the Born Project has come up with a tool at this website that I've listed here, and you can find this in your syllabus as well. You can log on to this and take a fairly easy course, and it will help you to recognize the abnormalities of Barrett's much better. We need to utilize the PROG criteria as it's essential in assessing Barrett's esophagus. And again, we need to strictly follow Seattle protocol to obtain our biopsies in Barrett's esophagus. We want to improve our Barrett's esophagus surveillance as well. And there are 10 steps to approaching high-quality examinations. And this comes from Sachin Wani and Jay Kolb from recent articles that were published. Our approach is to identify esophageal landmarks, including location of the diaphragm, gastroesophageal junction, and squamocolumnar junction. This is critical for future exams, and it is a clear quality indicator. We want to consider the use of a distal attachment cap to our endoscopes, and you can use several different varieties, a stiff or a flexible cap. This helps to facilitate visualization. We really need to clean the mucosa well using a water jet tannel, sometimes with simethicone, and carefully suction that fluid out. That removes any mucus, blood, or trauma available. Use carbon dioxide insufflation and desufflation to visualize the mucosa as well. We also need to spend adequate time inspecting the mucosa, the so-called BIT, or Barrett's inspection time. Some people advocate 1 minute per centimeter of time for each centimeter of Barrett's esophagus. We want to examine all of the Barrett's with high-definition white light endoscopy, which is available on all of our current endoscopes. Again, standard of care and a quality indicator. We want to use virtual chromal endoscopy, and again, these are integral into the tools that we use in all endoscopes at this point in time, and all endoscope manufacturers have a certain type of virtual chromal endoscopy in their scope. Everybody should learn and use the PROG classification to describe the circumferential and maximal extent of Barrett's esophagus, and these are in all standard reporting systems that you use at this point in time. We should also be using the Paris classification to describe superficial neoplasia. And again, if you go to the Born project, you will learn how to use the Paris classification easily. Seattle protocol should be used in all patients for increasing our yield and dysplasia. So again, everybody has high resolution white light endoscopy, electronic chromo endoscopy, magnification, and a lot of people are using Watt's tissue brushes, which I'll describe in a little bit. Limited availability of confocal endomicroscopy, molecular imaging, and AI, which will be coming as well. Electronic chromo endoscopy includes FICE, NBI, and iScan. These are filters that adjust blue and green light, similar to hemoglobin, which provides better emphasis on mucosal detail. These are the tools that we have and what happens. NBI is the application of 2 filters, whereas iScan and FICE are post-processing filters, which can be applied to the images and be seen in real time. And these will demonstrate surface analysis, tissue analysis, as well as vessel analysis. This is a picture of a patient I evaluated yesterday with Barrett's esophagus. You can see much more clearly the detail of the Barrett's esophagus using NBI. So we used high definition white light endoscopy on the left, and then NBI on the right, noting these changes much more clearly and identifying the extent of the Barrett's. I can also use high magnification for this as well. So the blue-green light on NBI highlights superficial vessels in the blue light and deeper vessels with the green light. And this will provide a much clearer image of what's happening. This is a nice description of the PROG classification, and there are several steps that we do. We want to look at the distal esophagus initially and identify if there's any hiatal hernia. The second step is to locate this gastroesophageal junction and note at what diameter from the incisors that is. We want to look at the top of the gastric folds to identify this. We look for the displacement of the squamocolumnar junction above the GE junction, and that will be the maximum extent. The measure of the depth of the endoscope around the circumference is the circumferential extent of our suspected columnar metaplasia. The maximum depth is also then measured, and that will be the M part of the PROG classifications. We subtract the depth of insertion for circumferential and maximal extent from the depth of the endoscopic insertion at the GE junction, and we can come up with a formal PROG score. And in this cartoon, we can see that it's a C3M7, meaning that this is circumferential Barrett's for 3 centimeters, but the maximal extent will go up to 7 centimeters. Seattle protocol is the current standard of care and should be followed by all endoscopists, in which we take systemic biopsies taken from 4 quadrants every 1 to 2 centimeters throughout the extent of visible Barrett's esophagus. Each section needs to be placed in a separate formalin jar and sent to the pathologist. Any visible lesion, meaning a nodular lesion, should be biopsied and processed separately in a different jar. My own personal practice is to take a biopsy every centimeter, every 4 quadrants, to increase my yield of detecting dysplasia. So again, this is just an example of looking at Barrett's esophagus with the PROG classification and then where to take these biopsies. These X's highlight the 4 quadrants every centimeter. A newer tool, which is called the Watts CDX brush, is wide area transepithelial sampling. This brush allows the acquisition of much more tissue than just a single biopsy. The specimen is collected and it is disaggregated combination of intact tissue fragments, which are microbiopsy cell clusters in individual cells. The sample is sent off to a proprietary lab. They use AI in this microscopic examination to help with the GI pathologist. They also take 50 slices of this 3D image using immunohistochemistry of CDX2, MUC2, P53, and Amicar. A recent registry study by Nick Shaheen in the American Journal of Gastroenterology this year identified about 24,000 patients with GERD. All these patients underwent Watts biopsies. 80.5% additional cases of dysplasia was detected by Watts over biopsy, demonstrating certainly an increased yield of this. One of the things that comes up with this study, though, is 62% of the dysplasia was limited to crypt dysplasia or were indefinite dysplasia. So still a pretty good yield, but some limitations to it as well. PCLE is another tool which allows real-time histologic assessment of the esophagus, provides 12 images per second with a depth of penetration of 50 to 150 millimeters. It does require IV fluorescein. This is the tool that we see. This is the hardware. This is a probe that goes down the esophagus and can be done real time. This on the left is non-dysplastic Barrett's esophagus, which you can see very clearly, columnar cells. You can see these goblet cells here, which are dark. And this is a contrasting image of dysplastic Barrett's esophagus, where you can see this complicated structure of the esophagus. But clearly, you can see the difference in these two samples. Another tool that we now have available is TissueCypher. It's a newer tool which assesses 9 protein-based biomarkers, and a numeric score is provided to describe high or low risk progression. The TissueCypher assay is performed on biopsy tissue that you've already obtained. It can be sent out to a proprietary lab after you get back your biopsy specimens. There are now 5 studies available showing that this is a fairly good way of looking at these patients for high risk. These are the 5 studies that we see and will be included in your syllabus, so you can take a look at this, but you can see that there is a quite good correlation between the high risk and not. This is the report that you get back from the lab, and this was a patient that I did that shows a very high risk score. So he will require more frequent screening. We talk about this at length with the patient and the risk of progression. Now let's get to some of the more important types of things associated with Barrett's esophagus as well. Management. There's medical therapy as well as endoscopic eradication therapy, which is reserved for patients with dysplasia. Our approach to treatment of Barrett's esophagus is certainly medical, and we want to treat all patients with Barrett's esophagus indefinitely with a proton pump inhibitor. Now, you get a lot of pushback from your primary care doctors as well as the patients talking about long-term use of this. However, it is shown to be very effective at controlling Barrett's esophagus and maybe preventing progression to dysplasia as well. It's unclear if fundoplication is as effective as PPI in reducing cancer risk. The use of aspirin and nonsteroidal anti-inflammatory agents have also been shown to decrease the risk of development of esophageal cancer in patients by up to 40%. But it's really not routinely prescribed for the purpose of chemoprevention due to potential adverse effects. Now, endoscopic eradication therapy is really important. Our goal is to reduce the risk of cancer, cancer-related death. Risk reduction should be durable and without the need for repeat treatments. And our ideal treatment for Barrett's is easy to administer without significant complications. We want to resect any neoplastic lesion that has a high dysplastic grade. We want to eradicate the rest of the remaining Barrett's esophagus to reduce any risk of metachronous neoplasia. We want to be able to manage our complications, and then we have to enroll patients in surveillance programs. So our current endoscopic tools include those that can remove visible dysplasia, either EMR or ESD, and then ablation of flat dysplasia can be done by radiofrequency ablation, 2 forms of cryotherapy, hybrid argon plasma coagulation, and endorotor. Both of those last for refractory Barrett's esophagus. This is our target. This is the human esophagus. And we can see here the top layer is the muscularis mucosa, and our target for RFA and cryo are the top layers. EMR depth gets down to the submucosa, and surgical depth is to remove the entire esophagus. So as I stated before, we want to do complete endoscopic resection of any visible lesions that need to be performed. If you're not trained to do this, it's easy to refer to an expert in your area rather than going ahead and doing biopsies of these, because this, as with colonic polyps, can lead to difficulty in removal of the tissue. EMR is always followed by ablation of residual flat Barrett's esophagus, and it's superior to stepwise radical endoscopic resection due to the high rate of stricture formation in the patients that undergo complete resection. Endoscopic ablation is performed every 3 months until complete endoscopic eradication of all columnar epithelium is achieved, and mucosal ablation should be applied to all visible esophageal columnar mucosa, 5 to 10 millimeters proximal to the squamo-columnar junction, as well as 5 to 10 millimeters distal to the gastroesophageal junction. And this is generally used either with a focal device or circumferential device with RFA. The endpoints of endoscopic eradication will continue until all of our high-definite white light endoscopy and or optical chromoendoscopy shows resolution. These are the ACG guidelines for endoscopic eradication in patients with high-grade dysplasia or IMCA. It's moderate quality evidence. In patients with low-grade dysplasia, we want to reduce the risk of progression, and moderate quality evidence as well. Initial endoscopic eradication of any visible lesions before ablative therapy, the quality of evidence is very low, but certainly very important. We want to suggest that all patients with Barrett's esophagus undergoing EET be performed in high-volume centers, because we know that the results are much better in that situation. And patients who have completed endoscopic eradication therapy should be enrolled in endoscopic surveillance program. Radiofrequency ablation is really the workhorse of treatment of dysplastic Barrett's esophagus. It provides direct visualization of the treatment site, and there's multiple different tools that are available, including circumferential using the Halo 360 Express, as well as the focal devices, the Halo 90, the Halo 60, and the through the scope device, which are sector-based techniques. Procedures are fairly quick, averaging about 20 minutes. And it does take several sessions with a combination of all of these tools to totally eradicate the Barrett's esophagus. A recent systemic review and meta-analysis showed complete resolution of intestinal metaplasia in 78%, with complete eradication of dysplasia in 91%. Complication rate includes strictures in 5%, pain in about 3%, and bleeding in about 1%. This is the tool, this is the balloon that is inflated in the esophagus. Electrical energy is then supplied, causing radiofrequency ablation with destruction of the mucosa. You can see here in this cartoon, we have a 3 centimeter length of the balloon. We advance that to the second segment to get complete eradication of the tissue. There are 2 different types of cryotherapy that are available, including CSA, which is a spray catheter using liquid nitrogen, and then a C2 balloon, which is a newer type of tool. Cryotherapy works by causing rapid freezing and then thawing, which destroys tissue by immediate and delayed effects. Causes intra and extracellular ice. It tends to disrupt the cell membranes. You get tissue ischemia, vascular stasis, endothelial damage, and vascular thrombosis. There may be some apoptosis that is at work here as well. The CSA tool uses liquid nitrogen at minus 196 degrees at 2 to 4 psi. This gas will this liquid nitrogen will turn into a gas, and we use oral gastric suction to eliminate this. This is done under direct visualization, short treatment sessions. This is the C2 balloon, which provides a focal device, which will also use nitrous oxide to help freeze, and you can get a very well-controlled application of cryotherapy to the site of the Barrett's esophagus. EMR is great for resecting macroscopic visible discrete lesions less than 2 centimeters, and it can be used for wide excision, but rarely now for circumferential excisions. The advantages of EMR and ESD are to provide definitive histologic diagnosis. It's a potential for a cure, and it's safe and effective for complete resection of superficial nodular lesions. The disadvantages to this treatment is bleeding, perforation, and stricture formation, and up to 37% with circumferential resection. This is a case that was recently done with the nodular Barrett's. You can see that I've used APC to mark this lesion. We go down with a cap, like we do with varices, and we aspirate the tissue into the cap and then place a rubber band around this lesion. Once this is secured, we'll then take a snare and go back and resect this just as we would with a polyp. Gives a very nice lesion here to resect. And we can capture that lesion, send that out for pathology, and get additional deep tissue for this. In 3 months, we will go back and treat the rest of this area with our treatment of choice, either cryotherapy or radiofrequency ablation. Now, this is key. After we do EMR, we want to look at the depth of penetration. So we look for lesions that are either superficial or T1A lesions, and these are reserved for endoscopic therapy. If we have T1B or deeper lesions, these are reserved for surgery at this point in time. So it's crucial to identify the extent of depth of penetration. We know that with T1A lesions, the risk of lymph node metastasis is quite low, but with a T1B lesion, it can be quite high with reports of either 25 to 40% lymph node invasion. There's been a recent report at DDW this past week, which says that potentially T1B lesions may be amenable to endoscopic therapy. We need additional research for that. How effective and durable is endoscopic eradication therapy? This is a slide from Sachin from the University of Colorado. You can see here that in the yellow, complete eradication of intestinal metaplasia is very good. Complete eradication of dysplasia is also excellent, with a very low recurrence rate in these multiple studies. Refractory Barrett's esophagus does occur in about 20%, and the causes are typically ineffective acid suppression, low volume endoscopist, or long segment dysplastic Barrett's. Our solutions to this problem are to optimize acid suppression using BID PPI, H2 receptor antagonist at bedtime, and consider endoscopic surgical or surgical fundoplication. Cryotherapy has been used in these rescue cases, and there's an additional pooled complete eradication of intestinal metaplasia of about 46%. Referral to a high volume center may be considered in these patients as well. There are several models that are based upon follow-up after complete eradication of intestinal metaplasia, and I'm going to leave you to review this in your syllabus as well. Adverse events of endoscopic therapy. Over a meta-analysis over 9,200 patients, overall complication rate is pretty low. Stricture rate, as I mentioned, is about 5%. Bleeding was 1%. Perforation rate is very low. The most significant is post-procedure pain, which is observed in about 4%. We can control that with viscous lidocaine in most cases. Rarely are narcotics needed. I want to just review quickly the ACG guidelines for diagnosis and management of Barrett's esophagus. If we see Barrett's esophagus less than 1 centimeter, it's really not Barrett's esophagus, and there's no need to biopsy these lesions. For lesions that are greater than 1 centimeter, we want to obtain biopsies in a Seattle protocol biopsy specimen. For those who have intestinal metaplasia with no dysplasia, then we can do surveillance every 3 to 5 years. Indefinite for dysplasia, we want to confirm this with a second pathologist. We treat with PPI and then repeat an endoscopy after 6 months. With low-grade, high-grade, and early esophageal cancer, we always want to confirm by a second pathologist with GI experience, and then we refer to the next flow chart for treatment. And again, after expert pathology review, low-grade dysplasia, we discuss the risk and benefits of surveillance with endoscopic eradication therapy. We can perform surveillance or do endoscopic therapy, and after achieving eradication, enroll in a surveillance program 1, 3, and every 2 years. Those with high-grade dysplasia, we want to resect all visible lesions and then treat with either RFA or cryo. And then once completely resolved, baseline, start with 3, 6, and 12-month surveillance, and then annual. Submucosal or T1B cancer gets a surgical referral for esophagectomy. If it's a very high-risk patient, we can consider using endoscopic therapy. My conclusions are that Barrett's esophagus affects approximately 5% of the people in the US and approximately 1% worldwide. Barrett's esophagus is associated with an increased risk of esophageal cancer. First-line therapy for Barrett's esophagus consists of proton pump inhibitors for control of reflux symptoms, and surveillance with upper endoscopy is recommended by practice guidelines over multiple societies. Adenocarcinoma is clearly a problem, and Barrett's is the precursor lesion. We need to screen these patients effectively, and you need to be very compliant with these guidelines. We want to always use high-definition white light endoscopy as well as virtual chromo endoscopy. We have a lot of different adjuncts now that are available to assess risk, and new non-endoscopic methods may help us increase screening at a PCP level. So consider speaking to your primary care doctors about the use of these tools, as that may actually drive more patients to you. Primary care doctors certainly need to be thinking about Barrett's screening in the future. Lifelong medical therapy is essential to control Barrett's. Surgical treatment of GERD may be required for the treatment of Barrett's as well. Multiple effective endoscopic therapies are available, including all the ablation techniques that we talked about to prevent progression to cancer. EMR and ESD will allow pathologic evaluation and may be curative as well. Surgery may be needed if Barrett's esophagus progresses to invasive adenocarcinoma. Thank you very much for your time, and enjoy the rest of the course.